great pleasure tonight to introduce Professor Peter Gordon. He's a special person to me. I think after tonight he'll be a special person to you as well. He brings an enormous amount of clinical expertise to be able to talk about the history of anesthesia. He ran the clinical department, or headed up the clinical side of the Department of Anaesthesia at UCT, which encompasses all the hospitals in the Western Metro of Cape Town for many years. He's an accomplished anaesthetist. He did all the pioneering liver transplant work that started the program in Cape Town. He tells me he's anaesthetized probably 90% of the liver transplants that were done during that time. He was the one who went to the States to learn the technique, came back and has taught everybody else. So the current program is basically based on the anesthetic expertise that Professor Gordon brought back. He is responsible for a huge number of things, but he also managed to do a huge amount of clinical anesthetics. And I don't know how many cardiac anesthetics he has done, but certainly he was one of the people who came into the program soon after they'd started the heart transplant program. And so he did a huge amount of the early cardiac work in Cape Town with the big surgeons who were around at the time. And a lot of people who are prominent players, certainly in the South African cardiac field, have trained under people like Peter Gordon. And so when we worked with him, he had a huge number of tasks. He managed to publish a lot of work, and he was doing all sorts of things whilst running a department and giving anesthetics. And he retired a few years back. And you just realize how much energy he had and he was putting into that job, because he shifted almost all of that. He does a little bit of teaching and a little bit of clinical work still, but all into the history of anesthesia and the history of Anesthetic Museum at the University of Cape Town's Department of Anesthesia. And it's quite unbelievable. You walk into the department, you have to kind of work out where he is, and because if he catches you, he says, "Ant, come and see, I found this, and have I showed you this?" And then you've got half an hour about this little thing and why this one is different to the one in the cabinet next to it that's slightly different, but this one has been given by somebody in Australia in response to him chasing up things. So I think you're in for a ride tonight. The enthusiasm, you cannot you can't stick anything on him for lack of enthusiasm for the history of anesthesia. He's just come back from the American Society of Anesthesiologists national meeting, or annual meeting, where he was invited to talk about the history of anesthesia and particularly Africa and Southern Africa and that. So he really is an expert, and I'm sure you're going to feel some of the enthusiasm that he will impart tonight. So yeah, thanks Pete for agreeing to speak.
And evening, ladies and gentlemen. It's a pleasure to be here this evening. I'm sure you were enthralled yesterday at seeing the scope and the safety of modern anesthesia, and I'm going to show you that it wasn't always so, and take you back right to the early days. Let's see if we can get this. Sorry, could you hear that? I started repeating. Shall I? Okay. Surgery before anesthesia was a brutal and extremely painful experience. The screams were beyond belief. There's a museum in London where they moved the theatre from next to the female ward to above the church. It's just near the Shard. And it was undiscovered for many years. And the reason they moved us there was because the woman complained about screams that were emanating from the theatre, which was built in 1822. At that time, patients were held down forcibly, blocks were sometimes put in their mouth so they could bite in their teeth, and surgeons were very, very quick. They had to be, they could chop off a leg in 3 minutes, and but there were very few operations that could be done. At the Massachusetts General Hospital, where the first anaesthetic was performed, they'd only done approximately one a month, just over one a month for the previous 5 years. And the cartoonists seem to agree with that wonderful painting. It was painted by an unknown artist and hangs in the College of Surgeons in London. Everything changed, however, in Boston in October 1846, when William Morton gave the first successful demonstration of ether to take away the pain of surgery during an operation on a young boy. He had a mass removed from his neck. And the surgeon said, "Gentlemen, this is no humbug." And there's the inhaler which Morton used. We've got an exact facsimile in our department. And the news spread rapidly around the world. It just took one ship, the SS Arcadia, across to Liverpool. Within 24 hours, there was an anaesthetic administered for minor surgery in London. And then 3 days later, Liston amputated somebody's leg using a medical student, Squires, to give the anaesthetic. And then just a couple of months later, April 1847, ether was being used in Cape Town by a Dr. Raymond, who claimed to have been trained in Paris, and extracting teeth using ether. And then, surprisingly enough, in Grahamstown, in June 1847, Joubert and Atherton gave the first anaesthetic for major surgery in South Africa using ether when a patient had been waiting for a number of years. He had gangrene of his leg, extremely painful, and Atherton experimented beforehand, decided that a milk bottle would be suitable because you needed quite a large surface area. He explained to the patient the day before how to use this device. The patient tried it out and said, right, he's prepared to give consent for the operation, provided he can tell the surgeon when to cut. He declared that this is what he said afterwards: "This is the greatest boon ever conferred on mankind. I've been totally unconscious of everything. The sound of that horrid saw still grates as in a dream. But as for pain, I felt not the slightest." And if you remember yesterday, somebody brought up, hearing is one of the last senses that disappears as you drift into sleep with anesthesia. So there we are. Atherton was a typical Victorian, an educated Victorian. He had multiple interests. He was a renowned mineralogist and geologist, and also a paleontologist. And when the Hope Diamond, the Eureka Diamond, was discovered near Hopetown in 1866, the diamond was sent to Atherton in Grahamstown, who identified it as being a diamond, and thereby triggering the Kimberley diamond rush. And interestingly, in May 1869, Atherton became the first person to use chloroform in South Africa. Okay, the early anaesthetists and the early doctors all had to go overseas for training, and these are some of the devices they brought back, which are of interest to us as anaesthetists. And that one on the left there, the Clover apparatus, that was used for many years, probably nearly 40 or 50 years. It was used in the Anglo-Boer War. All these devices are to be seen in our anaesthetic department. I'm going to talk briefly about the early anaesthetic agents, of which there were 3, ether, chloroform, and nitrous oxide. Ether, the first drug to be used, was relatively safe to use, but it was extremely difficult. Patients didn't like it. It was irritant. They coughed, they spluttered, and it took a long time to get them to sleep, and they often had severe nausea and vomiting afterwards. It was also potentially explosive if you mixed it with air or oxygen particularly, and had a spark. And because it evaporated so rapidly, you need large amounts in a hot climate like South Africa. Chloroform was much easier to use. Surgeons far preferred it because the patients would go to sleep quickly, but it was also far more dangerous. It was non-explosive. And these are just 2 of the early users of chloroform anesthesia. The first is a 15-year-old girl on the left, Hannah Greener, who unfortunately became the first recorded death under anesthesia. She was 15 years old, having a minor operation on an ingrowing toenail. It was done under chloroform. She'd had the previous side performed under ether successfully, and she died. The other one you might recognize, Queen Victoria. Now at that time, the church was violently opposed to anybody taking away the pain of labor. This had been ordained by God, perhaps punishing her or them for Eve giving Adam the apple. I'm not sure about that. But John Snow, who was probably the world's first anaesthetic specialist in London, persuaded the Queen to try chloroform inhalations during the labour of her 7th and 8th children. That she did. The Queen proclaimed that it was soothing beyond delight. And if it was good enough for the Queen, it was certainly good enough for lots of other people. This is just a reminder of how explosive ether could be. There was a big one in Somerset Hospital, but this one, Groote Hospital, 1954. And on the left, you can see what the anaesthetic machine looked like beforehand. They used diathermy 3 minutes after stopping the ether, but some of it had obviously tracked through enough to cause all the glassware to blow up. The patient was fortunately unharmed and was rushed to a theatre next door, and I wasn't aware that anything amiss had happened until afterwards. Nitrous oxide is not a liquid, it's a gas, so it has to be stored in cylinders under pressure. It was first suggested that it might be useful as an anaesthetic by Sir Humphrey Davy in 1800. People seem to forget that. And it was used as a recreational drug, a little bit of, I suppose, like ecstasy or alcohol today. And in this cartoon, which is from the Wellcome collection, it's entitled Prescription for Scolding Wives. So be careful, Louise. Nitrous oxide was a good analgesic, but it was a lousy anaesthetic in many ways because you needed virtually 100% nitrous oxide to guarantee anesthesia. And you don't survive 100% nitrous oxide because you've got no oxygen. It causes hypoxia. It's also expensive. It had to be imported from the UK. It was about a 3-month trip to send your empties back, at least 3 months, and then wait for them to come back again. And it was dangerous making the stuff. It was an exothermic reaction, and every now and then a factory would actually explode. Water vapor was also a big problem in the early days, and because it used to freeze up as the nitrous oxide evaporated in the cylinder, and that would block the outlet. And ways had to be found to overcome that problem. Okay, let's just go backwards one. Okay. McKesson was an American who designed this device which became known as the McKesson anaesthetic machine. That was used for at least 50 years, and it was exceptionally dangerous, the technique that he first described. It was called the technique of secondary saturation, where patients would be given 100% nitrous oxide until they turned blue, the pupils would dilate, and they would ultimately start fitting. They're called ejectitating. At that stage, they would give the patient a single breath of 100% oxygen, and this machine could do it. It could deliver both gases at a high pressure if needed. And then the anaesthetist would continue with about somewhere between 5 and 8% nitrous oxide, and over 90%, 5 to 8% oxygen and more than 92% nitrous oxide. If the patient still wasn't sedated enough, you would then repeat the process and go back to 100% nitrous oxide. And this is just the signs of fully developed nitrous oxide from the handbook which was recommended to anaesthetists in Cape Town at that time. And you'll see there that they recognize there that ejectitations are due to anoxemia, not enough oxygen, and indicates that the process of oxygen starvation has been carried as far as permissible. A lot of patients must have either been killed or knocked off mentally from that technique. Now I'm going to talk a little bit about some of the early anaesthetists. The first one was Dr. George Bampfylde Daniell, who was born and educated in England, and then came out to South Africa in 1889. He went to Caledon, where he became superintendent of the springs there, wrote lyrically about the health benefits. In the Anglo-Boer War, he became a silver surgeon, and then after the war ended, he returned to London to specialise in anaesthesia. He then became a lecturer at Edinburgh University, designed anaesthetic equipment, and returned to South Africa in 1906. In the following year, he was appointed as the first specialist to a hospital in South Africa, which happened to be the Johannesburg Hospital. However, he must have had a disagreement with the surgeons or something, because he didn't last there long. He came back to Cape Town the next year and went into private practice. While he was in Johannesburg, he described the decreased efficacy of nitrous oxide at high altitude, something that we're well aware of today. In 1908, South Africa's first medical school opened. It was under the August of the South African College, which later became University of Cape Town, and it opened for undergraduate, not for undergraduates, for preclinical students in their first 2 years of study. Thereafter, they had to go overseas to complete their training. By 1918, the new Somerset Hospital, which had been built in 1859, was ready. It had now become University of Cape Town Medical School, and they were ready to take their first students for clinical year of training. Bampfylde Daniell was appointed as an honorary anaesthetist, which meant that he wasn't paid for any work he did there, but he went there with the surgeon that he worked with in private practice, and from work done in private practice, the surgeon would pay him, which apparently was a pittance, in the order of apparently up to, or as little as 5%. Bampfylde Daniell was appointed a lecturer in 1921 when the students started doing anaesthetics. He gave the students, there were very few of them, so it was a very intimate affair, a course of 12 lectures, and often conducted at his home in the evenings, and they had to, each student had to administer 20 anaesthetics. The next anaesthetist I'm going to talk about is Dr. Royden Muir, who was born in New Zealand, educated in medicine at Edinburgh University, qualified just before the outbreak of the First World War. He became a ship's doctor, and then when war broke out, he volunteered and joined the Royal Army Medical Corps, and then worked as a ship's surgeon during the war. During the war, he visited Cape Town, fell in love with the place, and I think decided that that's where he liked to live. After the war ended, he returned to London to specialise, and then emigrated to South Africa to join Bampfylde Daniell in private practice in Cape Town. And he too became a lecturer of the university. For those of you ladies who like a little bit of star, he was married for a short time to Daphne de Waal, who was the daughter of the first administrator of the Cape Province. And interestingly, she tragically went blind shortly afterwards, but was a well-known poetess and an author. And in 1927, she moved to England. Royden Muir had been trained in England, but he realized that America could teach a lot. So in 1933, he went across to the United States, became the first South African anaesthetist to deliver a paper at the big annual Congress, and afterwards he visited, went on a tour of 10 major cities looking at anaesthetic practice. Premier anaesthetist at that time in the States was Professor Ralph Waters, who had become the first professor in the world in 1927. He was the chap who introduced the importance of keeping good records. He brought in carbon dioxide absorbers, which meant that you were then able to recycle the anaesthetic gases because this carbon dioxide is being removed, and therefore it became much more cost effective. And at that time he was experimenting with this new drug called cyclopropane, which was even more explosive than ether, but it had advantages, and it was a very, very rapid onset. It was almost as quick as giving somebody a shot of propofol. While he was there, he met Richard van Forriger, who was a big manufacturer of anaesthetic equipment, and he actually bought one of Forriger's machines, but when he got back to Cape Town, he wrote to Forriger and ordered one specifically for him for use in Cape Town. It was called the Muir Midget. And if you read there, it says, the exclusive and unique design of Dr. R.M. Muir, Cape Town, South Africa. And we have both of those in our museum. On his return to South Africa, he obviously went by boat. He stopped in at London and gave the first demonstrations of cyclopropane in Britain. He gave 15 anaesthetics at 5 different hospitals, and then returned to South Africa. Another fascinating character was Dr. Porrill, who, although he trained in England, claimed that he wasn't a specialist, but he was an expert. And he was obviously an extremely good anaesthetist. He was appointed to become Professor Saint's anaesthetist. And he was a great teacher and a great innovator, which you had to be in those days. I'm going to have to read this, but you can keep up with me. This is by Dr. von Herstraden, who was a medical student under him, and then eventually decided to become an anaesthetist himself. But this is what he described. When an endotracheal tube was essential, as for excision of the tongue for carcinoma, which was common then, Dr. Bampfylde was called in. He used a weird, primitive, electrically driven compressor arrangement fitted with multiple tubes and manometers to check the pressures in the lung. He passed 2 thin tubes, one for entry of gases and the other for exit of the mixture. We all thought he was a mechanical wizard and would have nothing to do with the machine. He continues, anesthetic equipment was primitive or non-existent at most hospitals. Supplies of compressed gases were difficult to obtain. There was an oxygen cylinder available in the theatre, but it had no pressure gauge or reducing valve, and if it was not empty, it usually blew the shipway apparatus to pieces when we tried to open the tap. Shipway apparatus was a device used to provide anesthesia using chloroform and or ether. Operations often had to be stopped owing to patients ceasing to breathe, but there were remarkably few deaths from cardiac failure. Surgeons were terrors and despised the anaesthetist. I can still remember Professor Saint, and as tight as a fiddlestick string, referring to the abdominal muscles when he was trying to operate on the abdomen. The path to recognition as a specialty was a long and arduous one. You can imagine at that time, if I'd been an anaesthetist in private practice, perhaps in a small town, this is what I would have taken with me. I would have been called out perhaps to some farm where somebody needed an anaesthetic, perhaps restricted labour, where they need to have a placenta removed or a fracture replaced. I would have taken this with me. It contained a bottle of chloroform, maybe a bottle of ether, a Schimmelbusch mask. This would have been used for dropping ether onto the mask. If you used chloroform, which is more likely because it was much easier to use, you would have had this little device where there's a pump, which you pump by hand, and this would pump air over the chloroform mixture, and then that would be delivered to the mask. So in 1927, the Medical Association declared that it was unprofessional to employ an unregistered person as a paid anaesthetist. And you can imagine when they went out to a farm, you don't know what you're going to find. They would have got whoever they could find, maybe the patient's wife or husband, to give the anaesthetic. The government, 1936, was worried that an increasing number of reports in the newspapers of patients dying in anesthesia. They instigated a commission of inquiry that anaesthetic attributable death is almost certainly a vast under-recording because the records were very, very poor. But what they did discover was that if you had a chloroform anaesthetic, you had 6 times as likely to die as if you had an ether anaesthetic. They also, in their findings, suggested that medical students and resident medical officers should have every opportunity of acquiring adequate practical experience of administering anesthesia. And it was desirable that in hospitals, trained anaesthetists should be employed, and part of their duty should be to teach residents. And Curtis Care, when it opened in 1938, there was one resident anaesthetist, Dr. Abelson. Right up until 1934, there were no specialist diplomas or degrees available for anaesthetists. The first one came about in 1935 when the colleges of surgeons and physicians in London decided to offer a diploma in anaesthesia. And 2 years later, you could become a specialist in America by passing the board examinations. Other countries took a long time to follow. 1953, Britain changed. They dropped the DA, and you could now get the fellowship of the Faculty of Anaesthetists. Many South Africans got both of those qualifications. The diploma in anesthesia there belongs to Harry Grant White, who got it in 1936, and he became the first professor in Durban. So Africa started with their fellowship in 1959. So before that time, if you wanted to specialise, you had to go overseas. 1938, the South African Medical and Dental Council were registering different specialties. And they declared that the administration of anaesthetics should be restricted to medical practitioners. However, dentists were allowed to continue to administer nitrous oxide. And remember, the dentists, they were the ones who started it all right in the beginning. They were giving the most anaesthetics probably for dental extractions. But what that did mean was that nurses in South Africa were not allowed to give anaesthetics. In 1944, I presume because the dentists were complaining, the Medical and Dental Council changed their ruling and allowed dentists to administer any anaesthetic. And that still holds today, much to the disquiet of anaesthetists who think that things have changed too much for that to be allowed, but that's another issue. All right, so how far had we come by 1937? Okay, that's now 90 years after Morton's demonstration. And this is a beautiful painting painted by Dorothy Kay, and I'm pleased to say that her granddaughter is in the audience tonight. Dorothy was an Irish artist, extremely good artist. She fell in love with a South African surgeon who was training over there at the time. That's him, the main figure there. And can I borrow your... And the anaesthetist there, if you look at him, there's not a piece of monitoring that you can see except for the anaesthetist. He's using the same drugs that would in use that many, many years ago. Yeah, okay, I'll use this one. Thanks. If I can work out how to work it. Good. Okay. Here's your monitor. The anaesthetist, undivided attention, finger on the pulse, listening to the patient breathing, occasionally looking at the pupils. And that patient was having a cholecystectomy. Right, in 1939, war was declared by France and Germany, by France and Britain on Germany, and South Africa followed reasonably once they'd sorted out the internal problems. And anaesthetists were suddenly needed, both at the front and to replace those who volunteered. A number of doctors went, including medical students such as Cecil Moss. And it's interesting that in 1939, there were only 10 specialist anaesthetists on the registrar in South Africa. During the war, anaesthetists in Johannesburg used to get together on a monthly basis and discuss interesting cases. And at one of these meetings, the anaesthetist in the painting there, from Moerdijk, suggested that they should get together and form a society of anaesthetists. Okay. What has this got to do? What has Pearl Harbour got to do with thiopentone? Thiopentone is a new drug that had come out not long before that. It was an intravenous barbiturate. It came in big 5-gram ampules, which is far more than was needed. And it was a dangerous drug to use in patients who were shocked, particularly if they've been bled out due to blood loss. And that statement is untrue. But there's no doubt that many patients did die because of people not knowing how to use thiopentone appropriately. Okay, so in August 1943, the South African Society of Anaesthetists was formed. At that time, it was the 9th oldest society in the world. And the things... Okay, that worked now. Okay, the two ladies you can see there, the one on the left, Hilda Ginsberg, became the first female specialist anaesthetist in South Africa, and both of them, flanking the president, became professors of anaesthesia in Johannesburg. Now, that year, the number of anaesthetists increased to 26, compared with 266 specialists who should require their services. So it was a vast mismatch. And the reason for that is anaesthetists it was exceptionally poor status attributed to them. Surgeons didn't appreciate the work that they did. They took too long. They didn't want them to use ether. They were poorly paid. There was no specialist qualification at that time. And there was a high patient morbidity and mortality. So who would want to be an anaesthetist? So at that first meeting, the president laid out what the aims of the new society would be, which would be to promote the science of anesthesia, in other words, good quality, to further the interest of anaesthetists which was to improve the remuneration and to determine professional relationships with hospitals, doctors, surgeons, government, and obviously patients. Royden Muir was elected as the next president, and at the first annual general meeting of the society in October 1944, Muir gave a lecture entitled The Teaching of Anaesthesia. And at this lecture, which was published in full in the South African Medical Journal, he compares the terrible state of training in South Africa at that time, and compared that to the facilities that were available in institutions in America. And then he laid down what he recommended staffing model, which should consist of a head of department and a full-time assistant, and then interns, I guess nowadays we call them registrars, who only did anaesthetics, and then other ones who would rotate through anaesthesia on a regular 2-week basis. And then he also recommended that the university should be giving postgraduate courses and should issue a postgraduate diploma. Royden Muir retired prematurely in 1946. He went over to London, returned to Cape Town on the yacht Carrier on the first leg of a round-the-world voyage, and died while climbing in the mountains of Lesotho. And the reason I bring this to your attention is this as a prelude to the obituary which appeared to him by somebody called G.S., which I'm pretty sure was George Sachs, who was a surgeon that would have been working with Roy at that time. He says in the obituary in the South African Medical Journal, his close friends knew that a mixture of two motives motivated his early retirement. One was his overwhelming passion for mountaineering and the sea. The other was a chronic resentment of what he imagined was the thankless role of the anaesthetist. He was entirely justified in this, for it is only in the past 2 or 3 years that the surgeons have belatedly and grudgingly recognized the inestimable value of the work of anaesthetists. The pyrotechnics of modern surgery are only possible because of the services of highly skilled and able anaesthetists. From being the handmaiden of surgery, anaesthesia has advanced to the state of complete equality. Roy Muir lived long enough to see this change and to rejoice in it. Now, that's not quite true, but certainly there was a change in attitude. After the war, there were huge changes in society around the world. Returning soldiers poured home, filled the medical schools and other classes at university. And at that time, there was a rapid expansion of surgical specialties. And the honorary lecturers were supposed to teach them. They just couldn't cope with the numbers. And so the government instructed the universities to employ more staff, but they didn't have money for that. And in the Cape and in the Transvaal, agreements were reached between the province and the university. In the Cape, it was signed in December 1951. It was called a joint agreement, whereby both, a 50-50 agreement, where both bodies would contribute towards the cost of staff. Universities would be responsible for teaching and research, and the CPA would be responsible for patient care. The 34th Medical Congress of the Society, 34th Medical Congress of all the South African doctors, took place in 1946. And that was the centenary of Morton's ether demonstration. So anesthesia was allowed to have a whole session to themselves. That's interesting. At the annual general meeting of the South African Medical Association, a surgeon, Mr. Radford, stood up and proposed that there should be the immediate instigation of a chair of anesthesia for South Africa. And this was unanimously accepted at the meeting. However, it took another 13 years before the first professor of anesthesia, Professor O.V.S. Koch, was appointed at Pretoria University, and the other universities followed slowly. Cape Town was particularly slow, I believe, in only appointing somebody in 1965. Another interesting character was Dr. Edgar Hacking, who emigrated to South Africa after the war. Excellent, was awarded an MBE for gallantry. And he was different. He was employed as a full-timer at Curtis Care Hospital, which meant that he wasn't reliant on the surgeons to be paid by them. And he believed that surgeons and a surgeon and anaesthetist were on equal footing, and this led to huge resentment and fighting. You know, often a huge stand-up rows, apparently. This was before my time. But eventually in 1951 he went into private practice, and then in 1960 immigrated to Tasmania, where he became head of department there and had the same fight with the surgeons in Tasmania. Maybe he was a difficult guy. Another one is became Professor Arthur Barclay Bull, who qualified at UCT in medicine in 1943, completed his internship in 1944, and then volunteered for the end of the war. Was drafted to 2 military hospital at Wynberg, where he fell in love with this new specialty and decided he wanted to be an anaesthetist. He became a medical officer at Groote after the war. In 1953, travelled to England, obtained a diploma in Anesthesia, and then in 1954 was offered an Nuffield scholarship to Oxford. This is to study under Sir Robert Mackintosh, who was the first professor of Anesthesia in Britain, and this is a wonderful experience. He used this new drug. It was so secret that it didn't have a name, and he did some of the pioneering work on this drug on animals, assessing its efficacy and safety. He then returned to Cape Town in 1956 to take over as head of department of that brand new Red Cross Children's War Memorial Hospital. It's a difficult task, you know, and one of the things he was interested in, or became interested in, was neonatal tetanus. At that time, it was a horrible disease. It came about because of often this practice of rubbing cow dung and soil on the umbilicus of babies in rural areas, and the little kiddies, tiny little babies, would have a horrible death, eventually dying in respiratory failure. And he got together with Professor Smythe, pediatrician, and they decided that it would be worth trying to intubate and ventilate these little babies and see whether they could actually make them improve the survival. At that time, of the first in the previous 6 years, there had been only one survivor of the 40 patients admitted with the condition at Groote Hospital. Bull managed to borrow an adult ventilator from the infectious diseases hospital at Somerset, brought it across to Groote, and then they had to modify this thing, which is totally unsuitable for a tiny little baby, not much bigger than a squirrel, perhaps weighing 2 kilograms. And he did it by having an accessory large bag there where the ventilator would blow into the bag, but part of the gas from the ventilator would actually be bypassed into the patient, and then on expiration it would all pass out through a one-way valve. There were no nurses. There were no intensive care units at that time. The nurses knew nothing about this. They had to be trained on the job. And in the first 10 patients, they reduced the mortality from down to 3. And there were another 2 patients who actually survived 7 weeks, but died of unrelated causes. And then Bull left Red Cross, became the head of department at Groote and the University of Cape Town, and Tom Voss moved. He had just come back from working in Wales, and he took over as the chief at Red Cross Children's Hospital, as the chief anaesthetist. And under his, while he was there, they further reduced, in a large number of cases, the mortality to 21% and then down to 10%. So this was paralysing patients, ventilating them, giving them all the other treatment to stop the seizures and that, and then allowing them time to recover. This is there were no devices suitable for anaesthetising tiny children at that time. And this was a thing called the Cape Town circuit, which was specially designed to reduce the dead space from putting the anaesthetic gases onto the tiny little mask which fitted over the baby's mouth and nose. But the problem is you didn't want the child to rebreathe gas because they would be rebreathing carbon dioxide. And by delivering, you can see that inner tube there, delivered the gas right at the inlet of the mask and therefore reduced their dead space. So that was designed by It was called the Cape Town Circuit, designed here, and Tom Voss published an article showing that that was the best of the 3 types of this system that existed in the world at that time. Tom Voss was a wonderful innovator. When he took over the department, there were no ventilators on anaesthetic machines. So you had an anaesthetic machine that looked something like that. What he did, he managed to couple a little green box there, which is a bird ventilator, to the anaesthetic machine. The problem was that the bird ventilator was driven by oxygen from under high pressure. And you didn't want that oxygen from the ventilator diluting the anaesthetic gases. So to prevent that, Tom Voss designed this thing called the elephant tube. And he experimented on different sized children, babies, to work out what you had to do. On inspiration, the oxygen would be blown down the tube towards the anaesthetic machine, but it would never reach the anaesthetic machine. Anaesthetic gases would be blown into the patient. When the patient breathed out, anaesthetic gases and excess oxygen would go back all the way down and out of this tube at the top there, where the green tube is. So this was used for many years at Red Cross Children's Hospital and at Groote Schuur Hospital. Another problem that they had, how do you measure blood pressure in a tiny little thing like this? There were no cuffs small enough. What Tom Voss did was he used a technique that was first discovered by the Reverend Stephen Hale in 1733, who wanted to measure the blood pressure in a large mammal. So they tied a horse down, stuck a catheter into its artery, and measured how high the blood column reached. And that was the mean arterial blood pressure. So Tom Voss did the same, except he used a water column, put it on a broomstick, catheterized the artery, and was able to, with these tiny little babies, keep record and track of the mean arterial blood pressure. And it was this technology which allowed the successful separation of the Siyepu twins in November 1966. These were exciting times at Groote Schuur Hospital and Red Cross, and I guess around the world. But the following year, South Africa and Groote Schuur shocked the world by performing the world's first successful heart transplant. You know, the world is absolutely amazed. How could it happen in Cape Town? The technique that Osinski, the anaesthetist, used, just people who come from America or elsewhere, they just drop their mouth in disbelief when you tell it. He used no opiates. Very soon afterwards, that became the fad. He used very, very high dose opiates, 200 to 300 milligrams of morphine as a sole anesthetic for cardiac surgery. But the downside of that was that you had to ventilate patients to 2 days because they wouldn't breathe for 2 days. Was he used no opiates, nitrous oxide and oxygen and halothane anesthetic, using a little bird ventilator, and no sophisticated monitors. The world was amazed, but they shouldn't have been. Since Chris Barnard had arrived back in Cape Town in 1958, the team had done nearly 1,000 operations under bypass. Professor Bull had experimented with halothane in dogs on bypass to see whether it was safe to use for cardiac surgery. And then this article was published in the British Journal of Anaesthesia in 1960, where they wrote up 44 cases, I think it was, of a technique using nitrous oxide and halothane for open heart surgery. And also, Osinski had done a lot of work with Chris Barnard in the animal laboratory, putting in hearts. This is the anaesthetic machine they used. There's Tom Voss's modification on it. Very, very simple. You didn't need electricity to run the anaesthetic machine. We could do with a few of those today. Professor Barnard hit the headlines. He got front page coverage on News magazine, Newsweek and Time magazine. Osinski was given a Society's gold medal by the state president at the 25th anniversary Congress of the Society in Bloemfontein. And I'm just going to go through that quickly. Right. I'm just now going to go through a few of the research highlights which took place at that time. The first one was a disease called malignant hypothermia, which you heard about yesterday. There's unfortunate families of patients who were totally unaware that they have this problem until they have an anaesthetic in which they're given either a volatile agent or scoline, and this huge metabolic explosion occurs in their muscles, where they just use up all the oxygen they've got to produce huge amounts of CO2. The temperature goes up and up and up, and eventually the patients die in multi-organ failure. And Harrison was aware of the condition, but he was working on pigs in the pig laboratory, doing work on transplantation of livers. This is quite a few years before we started the program here in Cape Town. And the surgeons couldn't believe it because pigs kept on dying. Not all of them, but a certain breed of pigs, the landrace pig. And then Harrison realized, in fact, something was happening to these pigs. They were getting hotter and hotter and hotter. They became known as the hot pigs. And he realized this was a porcine model of malignant hypothermia. So a huge amount of work was done at Curtis here with other departments involved in elucidating the metabolic pathways of this condition. Somebody suggested to Harrison that he might like to try a drug called dantrolene, which was a muscle relaxant. And he actually did that in an experiment. Here you have here, I'm afraid it'd be nice to have a pointer here, but let's see if I can get it to work. Okay, on the left there, this one here, you see going up and up and up. That's the pig's temperature shortly after the halothane was started. So here's the start of the anaesthetic. Halothane commenced. You can see the halothane there in the head spar at the top. And the temperature just goes screaming up, 37, 38, 39, 40, 41. At the same time, the heart rate, which is starting, his heart rate on the scales on the right, but starting at just about 90 per minute and shooting up to nearly 250 beats per minute. Okay, at that stage, Harrison stopped the halothane and administered the dantrolene. And almost immediately, temperature just came crashing down. It's absolutely unbelievable. And the heart rate came down with it. He submitted this paper to the premier anaesthetic journal in the world at that time, Anesthesiology, in America. They refused the article, saying it, he could maybe resubmit it as a letter or whatever. So he submitted to the British Journal of Anaesthesia, and it became a citation classic. Right, got a bit of a problem here. Okay, so it became a citation classic. Is it working?
This is a pointer. Okay.
Okay. That's it. Is it working? Okay, good. Okay. Citation classic, yeah. The British Journal of Anaesthesia, when they had their 75th anniversary, they got together their 50 most cited articles, and Harrison's 2 articles were number 11 and number 13. Harrison was an unbelievable researcher. He carried out the world's longest study of anaesthetic-related mortality at Curtis Hospital, 750,000 patients over 30 years. And in that time, he showed a 6-fold decrease in anesthesia-related mortality. At the end of a study in 1987, the mortality related to anesthesia decreased to about 0.7 per 10,000 anesthetics. Good. I'm now going to just briefly, I think it's getting late, look at some of the changes and monitoring that occurred. One of the earliest ones was a very, very simple device, where this device, this is a homemade one made by a colleague of mine, Dr. Howe, using inside of a telephone and clever circuitry. And what this thing did, you put it on your finger, it didn't tell you what your oxygen did, but this little device would go tick, 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 and you could count the ticks on your watch, and that was the heart rate. Right, the one on the left here was a much more modern one. This one actually gave you the heart rate, but also gave you the, and you could increase or decrease the amplitude as necessary. The device on the right, one of the things that anaesthetists were petrified of happening was that the oxygen would run out during a case, because you could then end up giving the patient pure nitrous oxide and kill them. And this was called the bosun whistle. It did whistle, provided you had remembered to switch it on to connect the nitrous oxide you had to do that as well, because when the oxygen failed, nitrous oxide would actually activate the whistle. If you forgot to put a little bypass in, it wouldn't work. It also had a red light that used to flash, and that was fine, provided the battery was working. so it had its flaws, but it certainly was a lot better. Okay, other devices made a huge difference. You heard yesterday about the pulse oximeter. Now, when I was a registrar at Red Cross, we had nothing like this. You knew your child was hypoxic when its heart rate started slowing down. You'd suddenly hear the heart going dup, dup. You knew the most likely, 90% chance, was due to hypoxia. The first thing you'd do would be to increase the oxygen. Occasionally, it might be due to the fact that you'd actually forgotten to turn down the halothane concentration. And halothane was a powerful drug for decreasing heart rate. Many little children died, particularly in the States, where they would use a high concentration of halothane in the beginning to get the kiddie to sleep, and then turn it down rapidly as soon as they were asleep. If you forgot to turn it down, you could certainly be occupied with something else, and your kiddie would certainly arrest. When I was at Red Cross, we were never allowed to use more than 2% halothane, because we had no monitor of halothane. But if you couldn't use more than 2%, your child could never get more than 2%, and you were unlikely to kill the child in that manner. The other device was the capnograph. Now, the capnograph was unbelievable, because here was a device that could measure the carbon dioxide concentration of each breath. If your patient stopped breathing, the trace would disappear. You could immediately pick it up. If you were underventilating a patient, carbon dioxide would increase with each breath. If you overventilated your patient, it would decrease with each breath. You could get a huge amount of information. If the heart suddenly stopped, what you would do, CO2 would accumulate in the blood and the tissues, but you would empty whatever blood was in the lungs of CO2, so the CO2 would slowly drop. If you got a sudden disconnection, the CO2 would go from normal trace to suddenly no trace at all. So this really was a marvelous device. And the same technology could be used for measuring the concentration of volatile anesthetic agents. So you now had a monitor that could actually tell us how much halothane or whatever drug was being used was being administered to our patients. Another very useful device was a nerve stimulator. Now, this is a very primitive one. It looks like a cattle prodder, and that's probably where the thought came from. But what you did, if you had a patient who was paralyzed, with this thing you could work out whether the patient needed a top-up by looking at the response to stimulating the ulnar nerve. If the patient was completely paralyzed, there'd be no response whatsoever. You could also use it for deciding when it was safe to reverse the muscle relaxant. And if the patient didn't breathe afterwards, you could use it to decide whether the patient wasn't breathing because they were still partially paralyzed or whether it was due to some other cause. So this was a very useful device. This is a much more sophisticated one of the type that we tend to use nowadays, and this can give us a lot more information. And then I'm going to take you to a rather sophisticated device called the Swan-Ganz catheter. And this was an amazing device developed by cardiologists in America. They were watching, one of them was watching yachts on a lake, and he suddenly saw the sailing boat going past, and he thought, the wind is blowing that yacht. If I can put a sail into the large veins in a patient, the blood flow will use that sail to take it on a trip through the heart. And that's exactly what he did. So here you have a multi-lumen catheter with a little syringe on the end there. You could blow up this cuff, as shown in the top on the right-hand side there, and then you could insert this to a large vein. Initially it was done through the femoral veins, but later on we'd usually use the internal jugular vein, and you would connect this up to a pressure transducer, and you could see exactly where you were from the pressure waves. And this thing would then feed it in, you'd watch it go into the right atrium, through the tricuspid valve, into the right ventricle, through the pulmonary valve, and into the pulmonary artery. And we could get a huge amount of information from this. We could measure the pressures in the chambers of the heart, obviously. We could, using a dye dilution or a thermodilution technique, measure cardiac output. We can measure resistance of both the pulmonary and the systemic circulations. We can measure oxygenation in chambers of the heart. So as it was passing through, the cardiologist could see if there was a septum defect between the right atrium and the right ventricle, because suddenly there had been much less oxygen much more oxygen in the right atrium than it should have been. Okay, and now a few South African anaesthetic inventions. The first one, this chap, Tony Cohen. I only recently found out that he was a South African when I was trying to get one of his little machines. It was called the Minivent, because 1966, when he invented it, was the year of the miniskirt. He was working at Baragwanath in the early 60s, Baragwanath Hospital in Johannesburg. There was one anaesthetic machine that had a ventilator on it, and the registrars weren't allowed to use it at night time. It was complicated to use, and that was kept for the specialists. So they used to have to sit there the whole night squeezing that bag. On the right there, you have a patient in our department that you simulated, but there's this tiny little ventilator sitting on your forehead. How did it work? I'll show you. We recently, Lawrence Howell, who's at the back of the thing there, the two of us managed to get it together, and what it did was, can you just get that pointer to work? Thanks.
Sorry.
Is it working? Good, okay. Yeah, you see that bag there? There I'm running 5 litres of oxygen per minute. That gas is going through into this reservoir bag, and a pressure builds up in that reservoir bag, which then passes down the tube here to go to the patient. That white bag there is representing the patient's lungs. When the pressure rises sufficiently in that bag, there's a little magnetic shuttle valve inside there, and the rise in pressure will push that valve away from the magnet, allowing gas to flow into the patient's lungs. The pressure would then drop in the bag, the little magnetic shuttle would shuttle back again, and the patient could breathe out through the expiratory valve over there. It really was a very clever little device, and we were delighted to be able to get it to work. I hope it works now. Whoops. No. I believe it doesn't work. Oh, there we go. Some of the noises, listen carefully, you hear that clicking. You could time it, and that would give you a respiratory rate. And if you divided the flow, which you could measure from the flow meter, if you divided that by the rate, you could work out how much per breath your patient was actually getting. Okay. Thank you. The next device was the Taurus blood warmer. And I'm delighted that you've got Professor Mason, who's visiting us here. He was one of the designers of that. This was a collaborative program between the Department of Electronic Engineering at UCT and the Department of Anaesthetics. It was named the Taurus blood warmer after Professor Bull. That's Taurus. The problem at that time, if you gave large amounts of blood, now blood is kept in the fridge at about 4 degrees centigrade to prevent infection and to make it last longer. And if somebody's bled out and you're having to give large amounts of blood in a very short space of time, all sorts of things happen. They become very hypothermic. That blood, usually, if it's been stored for any length of time, potassium leaches out of the cells, causes damage, and patients used to have cardiac arrest. So if you're going to transfuse fluids very rapidly, like we did later on with the liver transplants, you need to be able to warm the fluids. And so what they did using radio frequency induction was able to design this blood warmer that at that time blood came in glass bottles. So there you have, there's a dummy bottle, so you could check it to make sure there wasn't overheating the blood. And This was published around about 1966. It's been used ever since, not quite like that. A few years later, they started bringing blood, storing blood in plastic bags, so it changed. But we're still using the same technology today at Curtis Care Hospital. Unfortunately, the factory that makes these devices burnt down probably 15 years or so ago, and the dies were destroyed, and so we were unable to get new ones. But that's still. Okay, this is another little device. Designed by a Johannesburg anaesthetist, Jaime Sampson. This was widely used around the world, and it could be used either by doctors or by nurses for resuscitating neonates. When a little baby came out, wasn't breathing, you put this over the baby's face and pump away like this. And it was very difficult to over-distend the little baby's lungs. So this was used for many years. Jaime Sampson was a fascinating guy. His kids told me the story. They would be driving to school with him in Johannesburg, near Saxonwold, up here on Smythe Avenue. And he'd suddenly get an idea, and he'd just stop the car in the middle of the road. And he'd reach for his pen and he'd start furiously writing down. And I visited at his home when I was a medical student. And it was amazing because he'd be sitting there working in his garage on a lathe, making motorized little scooters for his grandchildren to play with. He designed lots of other anaesthetic equipment as well. A little bit about the College of Medicine and Surgery of South Africa. It was formed in 1954. At that time, there was a large division between the traditionally or the predominantly English-speaking and Afrikaans-speaking universities. The English-speaking universities had followed the English model, where you were awarded a fellowship by the Faculty of Anaesthetists of your particular college. And in 1962, the Faculty of Anaesthetists of the Royal College of Surgeons of England had granted full reciprocity to South Africa for our degree. The Afrikaans universities were distrustful of the English system. I guess the distrust goes back a long way, perhaps rightfully so. And they follow the European model, where universities awarded the internal MD or M.Med. And it was followed by Pretoria, then Stellenbosch, and the University of the Orange Free State. Today, that's all been put together in one. The College of Medicine now runs the exams, but all all anaesthetists in training, if they want to become a specialist, have to do an MD thesis as well. Okay. In 1995, we changed our status from a faculty of the College of Medicine to we now the College of Anaesthetists of the Colleges of Medicine of South Africa. And Professor Morel, who was head of department of Anesthesia in Johannesburg, became the first anaesthetist to become head of the College of Medicine. Okay, a little bit now, we're nearly finished, about the South African Society of Anaesthetists. Remember, they were formed way back in 1943. 1955, they became founder members of the World Federation of Anaesthetists. Currently, they've got over 1,000 members, run by a chief executive officer. They've got a president who's elected for 2 years, a council, and there are 5 business units. Education, private practice, public sector, regulation, and special interest groups. They've been producing guidelines ever since 1987. They produced the South African Journal of Anesthesia and Analgesia. 1994 was the start of a whole new era in South Africa and in medicine. Apartheid was dismantled, new health policies introduced, but this opened an opportunity for us to move into Africa. We'd never been able to do that before. Hannes Lewitz, the society president at that time, was invited to be a speaker and attend the first Zambian Congress of Anesthesiology. He was blown away by the reception he received. 1995 was also the year that critical care was registrable as a subspecialty of anesthesia, and also pediatrics and surgery. So there are 3 different ways you can become a critical care specialist. South African Society suggested in 1995 that an African Regional Society of the World Federation should be formed. Obviously, a number of problems to be overcome, language problems, the Anglophile versus the Francophile, Arabic North versus the Sub-Saharan South. And then most countries in Africa haven't got physician anaesthetists. However, the first All-Africa Congress was held in Harare. It was co-sponsored by South Africa in 1997. Gaisford Harrison from Cape Town gave the opening address. And at that meeting, the African region of the World Federation was formed. Okay, that's not coming out. It's just a slide showing in 2008, South Africa hosted for the first time, the World Congress of Anesthesiology. There were over 5,000 delegates here in Cape Town, and it was a huge success. Okay, I think that's about it. I'd just like to... modern electronics have their problems. And there on the left, you have a 1960s anaesthetic machine. Now, I know that that anaesthetic machine will probably still be working. Those mechanical components don't break. You might have to replace the odd washer or whatever. These are modern anaesthetic machines. A few years ago, while I was still working at Curtis Care, those were all sitting in the workshop. There was a problem with the company, and we had problems with the machine. And suddenly, the problem with the electronic machines, they're like fancy cars. The old-fashioned Beetle would carry on forever. You've got a fancy Mercedes-Benz or whatever. At some stage, electronic components are going to go, and you're going to have to spend a fortune if you're lucky enough to get your car to the garage to get that sorted out. And anaesthetic machines are much the same. Ladies and gentlemen, I've taken you from a voyage of 170 years from Morton's anaesthetic, 1846, so the first one in Grahamstown the following year. And you can see there's been huge progress. This is a modern anaesthetic machine that you saw yesterday. I've got no idea what it's going to be like in 25 years' time, and perhaps I'm grateful for that. 1936, there was one specialist anaesthetist at Curtis Care. This is our current department. Thank you for your attention. If there are any questions, I'll be happy to answer them. If any of you would like to visit the Anaesthetic Museum, please contact the Department of Anesthesia. Get my cell number, and I'll happily show you around. Okay.